let's see, moving forward again. So today's talk really is talking about a team-based approach to medications for opioid use disorder, normally presented by Dr. Larissa Lindsay, it should say, Director of Clinical Services at ASAP and for UNM Health Sciences Center, who is out today. And we're gonna start by talking about a team-based approach to care, as we talked about, really to maximize resources, right? Because one of the things that often comes up in our case discussions, especially from our rural partners, rural providers, is, well, these are all great ideas, but if we just don't have enough resources. And I think using a team model can be a good way to leverage limited resources. And I think that's really the important thing. We're going to talk about what different team members might help create a robust system of care within an office-based buprenorphine setting, and also go into roles and responsibilities for each team member, and how all this information may help with our clinical care, and the role administration can also play. So Jeanette, you said the PowerPoint you received is Cbt and Relapse Prevention. Doctor, I just see that in chat. So you are correct. That was going to be the initial presentation. However, Dr. Lindsay is out and she very much wants to do that talk, so she's going to present that next week. And then I'm just chipping in for this one for today. So sorry for the confusion, and welcome Sarah Hine. And yeah, Julie, we can talk about your chat right after this, perhaps. Thank you. So team approach. So if we're kind of going into that, right? So the key here at the heart of this slide is the fact that substance use disorders, as we've talked about, don't happen in isolation. We know that statistically, if an individual has a substance use disorder, they're significantly more likely to have another substance use disorder. They're also significantly more likely to have a co-occurring psychiatric illness, and vice versa. If someone has a psychiatric illness, they're significantly more likely to have substance use disorders. And the odds ratio is quite high. I believe it's about 4.5. So the likelihood of having kind of the co-occurring illness goes up across studies, by 4.5 fold. So this is very common. And at the heart of what this slide is getting at is the fact that study after study after study really points out that it's really integrated treatment that is the gold standard of care. So when someone has multiple substance use disorders, or substance use disorder and psychiatric illness, right, or medical illnesses, which of course our patients have, or even case management needs, things like stable housing, transportation, legal challenges, the best way to improve outcomes is by providing integrated care, right, which is really multiple service providers, multiple members of the team working together, and that improves outcomes. Gone are the days where the recommendation was kind of sequential care, where someone would have one thing treated, and then once that was treated, something else would be treated, because that doesn't work. To really improve outcomes, we have to be doing this together. That is the gold standard. And it needs, if it's going to happen appropriately, as this third bullet points out, there ideally should be one identified member of the team who's acting, right, as a coordinator, who's coordinating care and conveying a consistent message about treatment and recovery. We hear these terms, multidisciplinary and interdisciplinary. So in the introductory slide, really important to just quickly provide appropriate definitions, right? Multidisciplinary is really multiple different disciplines, several different disciplines who are all doing their own thing. But what we're really trying to achieve is interdisciplinary care, where there are these multiple disciplines, they all bring their perspectives, they all bring their expertise, but they're all coordinating, they're talking to each other and coming up with that integrated treatment plan and implementing it together. That's really what we want to try to be achieving, right, here as we go through this. So treatment team concept, I think the first slide I really like. What is recovery? So if you look at the definition of recovery from SAMHSA, for example, or from the American Psychiatric Association, it really points out that hope is at the center of recovery, right? Hope for the future. And there's some essential components of recovery that can include things like physical health, mental health, emotional health, stable housing, a sense of purpose, a sense of community. And all of those things are what comprise recovery. And recovery and remission interact, but they're not one and the same, right? As it points out here, recovery is more than just symptom remission or stabilization. And at the same time, as we've often discussed and talked about, right, someone can be in recovery and still not be totally abstinent or be in full remission. So the two interact, and there's a lot of data that's showing that when people, if we're able to help our patients get into sustained long-term remission, it in fact improves outcomes along all of those components of recovery and vice versa. So there's clearly a robust interaction that's going on, but two are not the same. And that's really what that slide is getting at. And including all the people who work with the patient. And of course, the patient themselves is crucial for success, because without that buy-in from the patient, as well as other team members, this concept of recovery can become elusive. And for it to really happen, right? And this is very consistent with our motivational interviewing spirit, that patient ought to be the charge, right? I mean, some of our patients say that, kind of the captain of the boat, where they're really in charge of their own health, while we may be subject matter experts. I may know a fair amount about substance use disorder. The reality is that our patients are the experts on their own lives, their own situations, circumstances, and the unique factors that might be contributing both to their illness as well as to their health and well-being. So we gotta involve the patient. We gotta involve the patient in a central way and have their buy-in. Otherwise, again, recovery is going to be an elusive concept. And once we have that buy-in, we really need an infrastructure in place to promote team cohesion, and which allows the team to work together and really focus on the good clinical work that we try to do. And there is an expectation that treatment teams use the treatment plan, right? It's kind of like Dr. Lindsay liked to call it the flight path, that it really helps to know what our flight path is, the flight plan is, because then everyone can work together to make sure that successfully happens. And she calls the treatment plan that initial plan that's fundamental to all clinical encounters and interventions. It gives us guidance as to what we should be doing, what we ought to be doing with a particular patient. So with that idea, let's talk about a little bit about what are the components of a successful team, right? And this really helps improve capacity. There have been, as you'll see, lots of models have been explored and continue to be explored that look at a team-based approach to treatment for patients with opioid use disorder, because there are only so many prescribers, right? I was looking at it recently, most recent data that came out by SAMHSA from like 2 years ago, that shows that still, if you look at all the people with opioid use disorder, only about 10% are receiving medication-based treatment for opioid use disorder. And another 10% are receiving non-medication based interventions, but vast majority are not. And there remains a significant lack of prescribers. So this can really help us leverage those limited prescriber resources. So who's on the team? So we often talk about kind of the core team and the extended team. So the core team, of course, is going to be the client themselves, along with the primary treating providers who work with the client. And then there's this extended team that can provide support and wraparound care, right? Who might work with the client less frequency. They might be at other agencies, but remained involved in the client's care, for example, concerned significant others. So what is the structure of the team? So I think this first bullet here is critical. And this was already pointed out in one of the earlier slides, that if we want the team model to be successful, there should be an identified, where everyone knows that this person is the team lead or the team manager who's responsible for kind of maintaining that treatment plan and coordinating efforts, right? This is often the primary person who works with the client. There should also be a coordinator or recovery coach who helps organize the team meetings, the communications, making sure that documents are tracked, recorded in the treatment plan. And it really helps. Again, part of that team cohesion is people understands each other's roles and be able to step in as needed and be flexible with it, as opposed to being super rigid, can really with the interest of providing patient-centered care. So team lead can be really any of these professions, right? As it says, an MD, a DO, RN, PA, NP, independently licensed therapist. That being said, in many of the models that have been explored empirically, it's often been the RN who has served as the clinical nurse manager or the lead of the team. For billing reasons, also because the RN may be able to handle many of these roles. So a lot of the models have really explored the RN as the team lead. So kind of putting it out there, but it really can be any of these professions. And they serve as that consistent point of contact for the patients. They do a lot of the coordinating. They may also have some patient care functions. So, doing some support groups, educational groups. As this points out, nurses have been most frequently utilized and studied in this capacity. So there's the team lead, who's sort of like working really closely with the patient, organizing the team, organizing efforts, holding the treatment plan. Then I think another key piece is the recovery coach engagement specialist. Can be RNs, very often they're CHWs, right? Peer support specialists. It does require training to step into this role, training that, for example, you're receiving through this ECHO program. Training about the basics of substance use disorders, trainings about stigma, trainings about the basics of medications. How do they work? What are the principles? Kind of addictions of the chronic disease model. A lot of those key components, the training is critical because this person often might be the one who has the strongest relationship with the patient. So you want to make sure that the message being provided is consistent, the patient feels safe, and it helps create a good rapport, and they really help expand services. They have some degree of administrative duties, including prior authorizations, checking PDMPs, maintaining buprenorphine logs for the prescribers, as well as some basic clinical duties, including taking vital signs, doing urine drug screens, pill counts, if indicated, administering some basic rating scales, right, screening for co-occurring disorders, and a lot of patient education. This is really where I think the recovery coaches shine, right, in some ways, providing that education to the patient on the basics of buprenorphine, as well as like the program expectations, harm reduction, and they often, again, facilitate communication between the patient and the team, as well as amongst other team members. And with experience, may facilitate or co-facilitate groups on things like overdose prevention, relapse prevention, and provide that psychosocial support to the patient, including checking in either in person or over the phone, as well as making referrals as needed. Some referrals. This is that extended care plan, right? That extends care that might be not within the agency, but things to keep track of depending upon the patient's circumstances, patient's preferences. 12-step programs, AA, NA, Smart Recovery, traditional healers, inpatient programs. It really helps to know what those resources are within your community and work to develop those relationships, because that can ultimately really wind up helping our patients. Of course, crisis line phone numbers, harm reduction sites, including syringe exchange sites, naloxone distribution, HIV, Hep C testing and treatment, emergency food sources, right, which can be really helpful to our patients, emergency housing and utility resources, employment and education resources, kind of really knowing what's available within your communities, and then the recovery coach often winds up facilitating these referrals, including psychiatric and medical treatment. Therapists, I think legally, again, therapy is not mandated, but it may improve outcomes for patients who are taking buprenorphine. It is, because often, again, our patients have underlying psychiatric illnesses, and the psychotherapy can be really helpful with it. And this lists many different types of psychotherapy, and really the key point that's provided by American Academy of Addiction Psychiatry is to not take the one-size-fits-all approach, that we really ideally want to provide psychotherapy that might be evidence-based for a particular condition, depending upon that patient's narrative, right? And this could be in-house or a referral, depending upon the resources within an agency. Pharmacists can be, we've got a pharmacy resident, like great allies in this, right? There's so much literature, pharmacy literature that's been coming out in the last couple of years that really looks at the role of pharmacists in terms of addressing and mitigating the opioid epidemic. And pharmacists have a huge role to play, starting with things like, of course, naloxone distribution, patient education, first responder and community education, identifying high-risk patients, right? But also co-prescription of naloxone. At this point in New Mexico, certainly there is a standing order, and anyone can go into a pharmacy and be able to receive naloxone. There are also models exploring pharmacists dispense methadone or pharmacists dispense buprenorphine, which have been studied in other countries more, but also on a limited basis in the United States with promising outcomes. So I think this role is likely going to continue to grow. Of course, APNs and physician assistants are going to be doing they're prescribers, right? So, they're going to be doing everything an MD or a DO is going to be doing with proper training. But the key thing here, the reason for including this slide is that the rules may differ depending upon which state you're in terms of the need to have a collaborating or a supervising physician. So really be sure to check the rules within your state, what those requirements may be. And then a physician, again, similar things, right? So, and our prescribers, really the key thing here is some of these things, right? Is doing the physical examination, assessing appropriateness for treatment, and providing the prescriptions, as well as really stepping into this role of educating the entire team to really bring everyone, at a level where they're able to function to the best of the, their best of their certification, right? Their professional capacity. So this is really coming from some of the models that have been explored using team-based care, specifically the Massachusetts collaborative care model that looks at different types of trainings. This is a reference slide, and who should be trained. So as you can see, there are many things where all staff within a clinic or agency ideally should be trained to ensure that we're providing non-stigmatizing, humanistic, and competent care, including basic understanding of addiction, or handling challenging behaviors, setting boundaries, addressing staff concerns, right? This should be a collaborative process where everyone feels comfortable talking to each other. But then there are some where there is a much more specific role, right? For example, kind of follow-up visit protocol. A lot of times in these models, this is run by the nurse care manager, often in conjunction or collaboration with a medical assistant, right? Things along those lines. So that's there. So this is the Massachusetts collaborative care model. Many models have been studied, but this has been one of the most kind of the original team-based models and remains quite evidence-based. And they really use this model. This is, of course, several years ago at this point, but really found that they were able to increase capacity for treatment significantly in a relatively brief period. And that's really the approach they took, that, they use the nurse care manager as that team leader as being central to the process. And then they actually found that combining one nurse care manager with one medical assistant, they were able to successfully and appropriately treat up to 125 patients, which is incredible. And they found this process to be viable and sustainable. And here, this is just looking at that care team, right? This is that extended care team that includes everyone from peer supports to care coordinator to the primary care provider, other specialty provider, and the care manager and the MA in this case really work closely with the patient to make appropriate referrals, to make appropriate connections. And this was the kind of the flow chart, the process they used, right? To really, again, leverage that limited prescriber resource. And this was actually done before CARA. So that's why it really says MD as opposed to MD, NP, or PA, right? This was initially developed before CARA came and before NPs and PAs were prescribing. So you can see, so initially, the patient's interested in treatment, that nurse care manager evaluates the patient, does initial screening, then the chart review happens by the entire team. So the entire team kind of a couple of times a week gets together, reviews the charts, says this patient is interested, right? And this can also happen, and ideally should happen in a more timely manner. So if the patient's there, the MA or the NP does the initial screening, they bring it up to the treatment team or the prescriber who reviews it, says this patient is appropriate, let's get them started. The MD does, of course, the chart review, the physical exam, provides the diagnosis and writes the prescription. A lot of the education, including regarding buprenorphine induction, follow-ups, happens by that nurse care manager, with the prescriber providing backup. So that's really kind of the heart of the model. And finally, the other role was, and this is just a reference slide looking at what the initial screening assessment was. And as you can see, part of the screening, they really placed heavy emphasis on patient education. That along with screening, the nurse care manager is doing a lot of patient education to increase engagement, right? And then finally, that prescriber played a heavy role in training of the staff. And that was sort of a unique role that was given to the physician within this model, including buprenorphine waiver training, right? Kind of basics of substance use disorders, basics of buprenorphine, how do you work with patients, training, shadowing opportunities, as well as providing that backup over telephone or email, and helping develop policies, etc. And this is a reference slide looking at some of the trainings that were a part of this model. Very similar to a lot of the trainings that we've been offering through this ECHO program, right? Finally, just a note here on administration. Lots of data showing that administrative support can be critical to success. And lack of administrative support can be a barrier to prescribers prescribing buprenorphine. And that's been looked at over the years and has emerged as a barrier. So that's really why this slide is there, that if there are any of your administrators, really support the clinical team. This is a life-saving intervention, can help our patients, our communities, and can be fulfilling and boost client morale if that support is there. So, create systems where communication happens, where people feel supported, both patients as well as team members, right? Clinicians, ensure there is appropriate coverage issues, appropriate staffing, and allowing time for ongoing education. So I think these are just a good slide showing that, be an advocate for our patients, advocate for policies that help our patients. Let's, work together to create anti-stigma environments. And I'll stop here. Thank you.